October 1942. Dachau concentration camp, Bavaria. Dr. Sigmund Rascher stood in a concrete chamber watching a man die slowly in a tank of ice water. The prisoner, a Polish political detainee, had been submerged for 90 minutes. His core body temperature had dropped to 25 degrees Celsius. He was technically still alive, but barely. Rascher meticulously recorded every physiological response, every involuntary muscle spasm, every desperate attempt at breath. The data he collected that day would save thousands of Luftwaffe pilots. It would also spark an ethical debate that continues in medical schools and research institutions 80 years later. The question is brutally simple and impossibly complex. Can knowledge gained through atrocity ever be used for good? The Nazi hypothermia experiments at Dachau produced some of the only comprehensive data on human cold water survival that exists. Modern trauma medicine, particularly treatment of hypothermia victims, still references findings that emerged from deliberate torture and murder. Every use of that data forces medical professionals to confront an uncomfortable truth: that sometimes the most useful information comes from the most unconscionable sources. The experiments began with a legitimate military problem. The Luftwaffe was losing pilots over the North Sea and English Channel at an alarming rate. Aircraft shot down or damaged would ditch in water that rarely exceeded 10 degrees Celsius. Pilots in standard flight suits survived perhaps 20 to 30 minutes before hypothermia rendered them unconscious. Death followed shortly after. The German Air Force wanted to know how to extend survival time, how to treat rescued pilots effectively, and whether specialized equipment could prevent hypothermia entirely. Heinrich Himmler, Reichsführer SS, saw an opportunity. Concentration camp prisoners were already being used for various medical experiments under the rationale that they were expendable, resources serving the greater good of the Reich. In May 1942, Himmler authorized Dr. Rascher, an SS physician with ambitions of academic prestige, to conduct systematic hypothermia research using camp inmates as subjects. The experiments would be thorough, controlled, and utterly without regard for the suffering or survival of the participants. Rascher established his research facility at Dachau using equipment funded directly by the Luftwaffe. He constructed specialized tanks large enough to submerge a human body completely. He requisitioned ice by the ton from local suppliers. He assembled measuring instruments, thermometers, stopwatches, blood pressure cuffs. All the apparatus of legitimate scientific research. The only thing missing was consent, medical ethics, or any pretense that the subjects were human beings rather than experimental material. The protocol was systematic. Prisoners were selected, stripped, and submerged in ice water, ranging from 2 to 12 degrees Celsius. Some wore flight suits, others were naked. Rascher measured how long it took for consciousness to fade, how core body temperature declined over time, at what point cardiac arrest became inevitable. He documented everything: pulse rates, breathing patterns, skin color changes, the exact progression from awareness to delirium to death. The suffering was methodical and prolonged. A human body submerged in near-freezing water experiences hypothermia in distinct stages. First comes the cold shock response: uncontrollable gasping, hyperventilation, elevated heart rate. This phase lasts perhaps 3 minutes and frequently causes drowning even in otherwise survivable conditions. The subjects in Rascher's tanks couldn't drown. They were held in position, forced to endure what came next. The second phase involves progressive cooling. Blood vessels constrict. The body attempts to preserve core temperature by sacrificing extremities. Fingers and toes lose sensation. Muscles become uncoordinated. Shivering intensifies to violent convulsions as the body desperately generates heat through muscle activity. This phase can last 30 minutes to 2 hours, depending on water temperature and body composition. Every moment is conscious, painful, terrifying. The third phase brings mental confusion and loss of consciousness. Core temperature drops below 30 degrees Celsius. The brain struggles to function. Victims become disoriented, sometimes paradoxically experiencing a sensation of intense heat and attempting to remove their clothing, a phenomenon called paradoxical undressing. In Rascher's experiments, this phase was particularly well documented because prisoners couldn't escape or undress. They simply descended into delirium while still visible to observation. The final phase is death. Below 28 degrees core temperature, cardiac arrest becomes likely. The heart muscle can't maintain organized electrical activity in extreme cold. Sometimes, the heart simply stops. Other times, it fibrillates uselessly. Either way, the result is the same. Of the roughly 300 prisoners subjected to Rascher's hypothermia experiments, approximately 100 died during or immediately after the procedure. Those who survived faced a second series of experiments focused on rewarming. Rascher tested multiple revival methods, some based on theoretical medical principles, others on pure speculation. He tried rapid rewarming with hot water. He tried slow rewarming with blankets and warm air. He tested the particularly grotesque theory that body heat from another person might be more effective than mechanical warming, forcing female prisoners to provide body warmth therapy to near-death male subjects. The sexual assault dimension of these experiments added another layer of atrocity to an already unconscionable research program. The data Rascher collected was extensive and, from a purely physiological standpoint, valuable. He documented precise relationships between water temperature and survival time. He established that rapid rewarming of severely hypothermic patients could cause fatal cardiac complications, a finding that remains relevant in emergency medicine today. He demonstrated that peripheral rewarming before core rewarming could shunt cold blood to the heart and trigger arrest, establishing the principle of core rewarming first that guides modern hypothermia treatment. In February 1943, Rascher presented his findings at a medical conference in Nuremberg, attended by senior Luftwaffe medical officers. The presentation was clinical, professional, complete with graphs and survival curves. The methodology section carefully omitted the fact that subjects were concentration camp prisoners who'd been deliberately tortured. The medical officers asked technical questions about water temperature gradients and rewarming protocols. No one asked about ethics or consent, because in Nazi Germany, those questions had been answered by ideology rather than medicine. The Luftwaffe incorporated Rascher's findings into survival training and equipment design. Flight suits were modified based on his thermal protection data. Rescue protocols emphasized rapid extraction from water and careful controlled rewarming. German air-sea rescue services used the survival time estimates to prioritize search areas and resource allocation. The data worked. It saved German pilots' lives, which was precisely the intended outcome of research built on prisoner suffering and death. If this examination of how wartime medical atrocity created modern ethical dilemmas is compelling, subscribing ensures you don't miss future investigations into history's uncomfortable complexities. The full scope of Rascher's experiments remained partially hidden even within the Nazi medical establishment. His written reports emphasized scientific methodology and practical applications. They understated mortality rates and omitted descriptions of suffering. But word spread among concentration camp networks. Prisoners knew that selection for medical experiments often meant death, and Rascher's hypothermia research had a particularly grim reputation. political prisoners, who formed a significant portion of Dachau's population, documented what they could in secret notes and verbal testimonies, creating a shadow archive of atrocity alongside Rascher's official data. The Nazi regime collapsed in May 1945. Allied forces liberated Dachau on April 29th, finding thousands of surviving prisoners and extensive documentation of various medical experiments. Rascher himself didn't live to face justice. He'd been arrested by the SS in 1944 on unrelated charges and executed shortly before liberation. But his research files survived intact, complete with detailed records of the hypothermia experiments. American and British military medical officers seized the documents. They faced an immediate dilemma. The data was scientifically rigorous in methodology, horrifying in execution, and potentially valuable for Allied military medicine. The U.S. Air Force was losing pilots to cold water hypothermia just as the Luftwaffe had. The medical knowledge Rascher had generated through atrocity might prevent future deaths. But using that knowledge meant implicitly validating research that violated every principle of medical ethics. The debate began almost immediately. Some military physicians argued that the data was worthless because it came from subjects under extreme stress, beyond the physiological effects of cold. Torture and terror, they argued, invalidated the findings by introducing uncontrolled variables. Others contended that physiological responses to hypothermia were likely similar regardless of the subject's psychological state, making the data scientifically sound even if ethically tainted. The Nuremberg doctors' trial of 1946-47 brought 23 Nazi physicians to justice for medical war crimes. The hypothermia experiments featured prominently in the prosecution's case. Dr. Robert Servatius, defending several accused doctors, made a startling argument. If the Allied powers intended to use the data from these experiments, they couldn't simultaneously claim the experiments were entirely without scientific value. The prosecutors rejected this reasoning, arguing that the experiment's criminal nature was independent of whether the data happened to be useful. 7 doctors were hanged. 9 received prison sentences. 7 were acquitted. But the data remained, filed in military medical archives, accessible to researchers who requested it with appropriate justification. The Nuremberg Code emerged from the trial, establishing principles of medical ethics, including informed consent and the right to withdraw from experiments. These principles directly responded to Nazi medical atrocities, creating safeguards intended to prevent such research from ever occurring again. Yet, the data persisted. Through the 1950s and 60s, researchers occasionally cited Rascher's hypothermia findings in studies on cold water survival and hypothermia treatment. The citations were usually indirect, referring to German wartime research or studies conducted during World War II. Without explicit acknowledgement of the experimental methodology, medical libraries maintain the documents, classified but available to accredited researchers. The ethical debate intensified in 1984 when Dr. Robert Pozos, a hypothermia researcher at the University of Minnesota, attempted to publish a paper that explicitly analyzed the Nazi data. Pozos argued that the information could help develop better survival guidelines for cold water accidents, and that failing to use available data was itself unethical if it meant preventable deaths. The controversy was immediate and intense. Holocaust survivors objected. Medical ethicists divided sharply. The New England Journal of Medicine rejected the paper, with editors arguing that publishing the data would dignify the atrocities that produced it. The core argument against using the data rests on several principles. First, using research obtained through atrocity creates an incentive for future atrocities by demonstrating that unethical research can produce lasting value. Second, it fails to honor the victims by treating them as having contributed to medical knowledge when they were actually murdered. Third, it violates the fundamental principle that some knowledge is not worth having if the cost is unconscionable. The data exists, but choosing not to use it sends a clear message that medical progress has ethical boundaries. The argument for using the data is equally principled, but differently weighted. Proponents argue that the victims are already dead and their suffering already occurred. Refusing to use data that could save lives doesn't undo the past, but does potentially create new victims who die from hypothermia when treatment informed by that data might have saved them. The knowledge exists whether we use it or not. Choosing not to use it doesn't punish the perpetrators or resurrect the dead. It only restricts potentially life-saving information. Modern hypothermia treatment does incorporate some findings that emerged from the Nazi experiments, though usually without direct citation. The principle of controlled core rewarming, the understanding of cardiac risks during revival, the survival time estimates for various water temperatures. These concepts appear in medical textbooks and emergency protocols. Whether they derived independently from ethical research or were influenced by Rascher's data is often unclear. Medical knowledge evolves through accumulated findings, and tracing the specific origin of any particular principle becomes difficult across decades of subsequent research. Some medical schools use the Nazi experiments as case studies in ethics courses. Students read about Rascher's methodology, examine the data's scientific qualities, and debate whether a physician facing a dying hypothermia patient should use knowledge that might help, but came from sources that violate every ethical principle. There are no easy answers. Some students argue for strict prohibition against using tainted data under any circumstances. Others contend that once knowledge exists, the ethical burden shifts to ensuring it never results from such methods again while using what we reluctantly possess to prevent future suffering. The modern consensus in medical ethics leans heavily against using data from unethical research. The World Medical Association's Declaration of Helsinki explicitly prohibits using research that doesn't meet ethical standards, regardless of potential benefits. The American Medical Association's ethics guidelines state that data from Nazi experiments should generally not be cited or used. The reasoning is clear. Ethical standards must be absolute, not consequentialist. Medicine cannot calculate that enough saved lives justify using knowledge gained through torture and murder. But exceptions persist in practice. Emergency medicine physicians treating severe hypothermia sometimes make decisions informed by patterns that emerged from Rascher's research, even if they've never read his papers directly. The knowledge has diffused into medical understanding through decades of secondary sources, textbooks, and training protocols. Trying to extract specifically Nazi-sourced information from modern medical practice is like trying to remove a single thread from a woven fabric. Theoretically possible, but practically impossible without unraveling everything. The hypothermia experiments weren't the only Nazi medical atrocities, merely one of the more systematically documented. Other prisoners were subjected to high-altitude experiments, infectious disease studies, poison testing, surgical procedures without anesthesia, and countless other horrors. Each produced data. Each raises the same ethical questions. The Dachau hypothermia research is particularly prominent because it generated some of the most comprehensive findings and because cold water survival remains a relevant medical and military concern. Dr. Rascher died never facing trial for his crimes. His subjects died without justice or acknowledgement. The data he generated sits in archives, occasionally referenced, more often avoided, always controversial. Modern researchers can investigate hypothermia using ethical methodology. Volunteers in controlled conditions with informed consent and safety protocols. progress continues without relying on atrocity. But the question lingers. In an emergency, with a dying patient and imperfect current knowledge, would you consult data that might help but carries the stain of unforgivable evil? October 1942. Dachau. Dr. Rascher recorded the death of another prisoner, his 92nd fatality in the hypothermia experiments. The data was precise, scientifically rigorous, and built on deliberate murder. 80 years later, that data still exists, still occasionally gets referenced, still forces medical professionals to confront the uncomfortable reality that sometimes the most useful knowledge comes from the most unconscionable sources. The prisoners who died in those ice tanks left a legacy they never consented to. Scientific findings that pose questions without satisfying answers about what medicine should do with knowledge gained through atrocity. The data remains. The debate continues. And somewhere in medical archives, detailed measurements of human suffering sit filed under Research Historical, with appropriate access restrictions and an asterisk that can never adequately capture the blood-stained origins of the information they contain.